Crohn's disease in pediatrics, a comprehensive overview for specialists. Epidemiology predominantly affects adolescents and young adults, with a bimodal age distribution peaking at 15 to 35 years and a second peak at 55 to 70 years. Etiology and risk factors, strong familial aggregation and genetic predisposition, e.g. NOD2 gene mutations. Tobacco smoking is a significant modifiable risk factor. Pathophysiology, characterized by transmural inflammation, possibly triggered by immune dysregulation in response to intestinal flora, leads to a variety of gastrointestinal and extraintestinal manifestations. Clinical features: gastrointestinal, chronic diarrhea, abdominal pain, commonly in the RLQ, weight loss, and possible complications like strictures, abscesses, and fistulas. Extraintestinal can affect joints, arthritis, eyes, uveitis, episcleritis, skin, erythema nodosum, pyoderma gangrenosum, and oral mucosa, aphthous ulcers. Diagnostics: endoscopy, key for diagnosis, revealing skip lesions, cobblestone mucosa, and ulcerations. Terminal ileum and colon are commonly involved. Imaging: MRI or CT enterography can show transmural inflammation, creeping fat, and complications like strictures or fistulas. Histopathology: transmural inflammation and non-caseating granulomas on biopsy samples. Laboratory tests may show signs of inflammation, elevated CRP, ESR, and anemia. Fecal calprotectin can help assess intestinal inflammation. Differential diagnosis needs to be distinguished from ulcerative colitis, UC, infectious colitis, and other causes of gastrointestinal symptoms. Treatment: induction of remission, corticosteroids for acute flares with biologics, e.g. infliximab, adalimumab for moderate to severe cases. Maintenance therapy, immunomodulators, e.g. azathioprine, 6-MP, and biologics to maintain remission and prevent relapses. Surgical intervention required in up to 50% of patients, mainly for complications, not curative but can alleviate symptoms. Now, medications. Biologics, anti-TNF agents like infliximab and adalimumab. Newer options include ustekinumab, anti-IL-12/23, and vedolizumab, integrin receptor antagonist. Immunomodulators, thiopurines, azathioprine, 6-MP, and methotrexate for steroid-sparing effects and maintenance of remission. Complications: local intestinal complications include strictures, abscesses, and increased risk for colorectal cancer. Systemic complications involve malabsorption, nutritional deficiencies, and growth retardation in pediatric patients. Prognosis: chronic relapsing course with variable severity, early diagnosis, and aggressive management can improve outcomes and quality of life. Specialists note it's crucial to adopt a multidisciplinary approach involving gastroenterologists, surgeons, dietitians, and pediatricians for optimal management of pediatric CD. Educating patients and families about disease management, medication adherence, and lifestyle modifications, especially smoking cessation, is key to long-term disease control. A 14-year-old male presents to the clinic with a 6-month history of intermittent abdominal pain, predominantly in the right lower quadrant. The pain is crampy in nature and sometimes relieved by defecation. He also reports non-bloody diarrhea, occurring 3 to 4 times a day, and occasional low-grade fever. Over the past few months, he has noticed a weight loss of about 5 kilograms despite no significant change in appetite. On physical examination, he appears mildly underweight for his age. Abdominal examination reveals tenderness in the right lower quadrant without rebound tenderness. No palpable mass is felt. Rectal examination is unremarkable, and there is no evidence of perianal disease. The rest of the physical examination, including joint, skin, and eye examination, is normal. The patient's laboratory tests show mild anemia, hemoglobin 11.2 grams per deciliter, and elevated inflammatory markers, CRP 15 milligram, ESR 30 millimeters per hour. Stool studies for infectious causes are negative. Fecal calprotectin is elevated. Given the clinical presentation and initial laboratory findings, a pediatric gastroenterologist is consulted and an ileocolonoscopy is performed, which reveals patchy areas of inflammation with scattered aphthous ulcers in the terminal ileum and ascending colon. Biopsies taken during the procedure demonstrate transmural inflammation with non-caseating granulomas. Based on the clinical presentation, endoscopic findings, and biopsy results, a diagnosis of Crohn's disease, CD, is made. The patient is started on induction therapy with a corticosteroid to manage the acute inflammation and symptoms. Additionally, due to the chronic nature of the disease and to maintain remission post induction, a thiopurine analog is initiated as a steroid sparing agent. The patient and his family are educated about the chronic nature of CD, the importance of medication adherence, and the potential need for further adjustments in therapy based on disease response and monitoring. The patient is scheduled for close follow up appointments to monitor his response to therapy, side effects, and to adjust treatment as necessary. Nutritional counseling is provided to address weight loss and support growth and development. The family is advised on the importance of smoking cessation, although the patient is a non smoker, and is informed about the potential extraintestinal manifestations of CD that may require monitoring over time.